So we left off in lecture talking about, some of the imbalances, some of the things that can happen if all of the electricity is not traveling through the heart correctly. Again, you may have irregular heart rhythms. They're called arrhythmia. It just means without rhythm. And I'm like, you might have the atria contracting too many times, the ventricles contracting too many times. There's not enough relaxation or repolarization in there. Fibrillation, that's when you just have rapid, irregular contractions. It's just nonstop electricity going all through the heart, and it's not holding it long enough for any particular chamber to actually empty and pump blood it like it's supposed to. And again, this is kind of what your fibrillation looks like. It's just all over erratic, nonstop electrical information going up and down. Also, and I'm like, if you have something that stops at the AV node, so again, it's not sending information from atria to ventricles, the ventricles are not going to receive information electrically, and so they beat too slow. And again, that's one of the main reasons a lot of people have pacemakers put in. The ventricles are not receiving enough information electrically to cause those ventricles to contract. Now, to record all of this, to be able to see what's happening electrically in the heart, we look at, and I'm like, an electrocardiogram. And I'm like, it's a record of all the electricity traveling throughout the heart. We can look to see where are these action potentials. We can see where the depolarizations, the repolarizations. And yes, this should look familiar from lab because you have that P wave. That's depolarization of the atria. That's what's happening at that sinoatrial node. The QRS complex, that's your ventricles are depolarizing and the atrials are repolarizing. And then you have your T wave, and this is when those ventricles are repolarizing, kind of resetting themselves. And so this, yes, should look familiar from lab. Now, and I'm like, this again is just showing you what's happening electrically, and I'm like, throughout the heart. So atrial depolarization, that's the sinoatrial node, is sending information through the atria, and I'm like, it's initiating that first depolarization. And I'm like, it will eventually send all that information. It will travel through all of the atria, and so it's got a slight delay there, and it goes to that AV node before it starts to travel down the ventricle. And again, there's that quick little 0.1 second delay at the AV node. Then it travels down through that bundle of His, bundle branches, and this is when you're going to start sending that electricity through that large ventricle area. And this is when we get ventricular depolarization. And I'm like, through that huge QRS complex. Again, atrial repolarization happens here, but it's so minor electrically wise. We just know that it's happening somewhere in here. And I'm like, eventually all the ventricles will have all of their electricity, and we have kind of a small little, split little time there before it starts to reset itself. And then you have ventricular repolarization. And when you have those potassium ions moving, we get this extra little uptake, and I'm like, of the T wave. And then eventually it levels back off again, and it's kind of nice straight line. And then again, you'll start right back over with the P wave. Now, this is looking at just some normal and abnormal ECGs. Again, your normal, you should have a P wave, a QRS complex, a T wave, a P wave, QRS complex, a T wave. And I'm like, that's kind of what you should see. Occasionally you can get it where I'm like, we're missing a P wave. It just goes QRS complex and this really big T wave. A lot of times that's a sign that your SA node is not working correctly. Occasionally you get that heart block, and I'm like, and you can start to get some excessive P waves, where you have P waves, but it's not sending any information down. So you can have, here's here's your T wave, and then here's a P wave, but here's another P wave. We're missing information in here because it didn't send it down into the ventricles. And then there's your ventricular fibrillation again. It's just chaotic, electricity everywhere, nothing's in any type of rhythm, nothing is in any particular order, and it's not sending electricity throughout the heart. Now, if you've ever at some point in your life put your ear on someone's chest, you can hear their heart sound, and it has two distinct beats to it. And I'm like, we call it the lubbed up. And so if you're listening, it sounds like lubbed up, lubbed up. Now, what you're actually hearing are the closing of the heart valves. The muscles themselves contracting don't make any noise. It's the same thing. If you move all of your muscles all around, you don't hear your muscles in your arms and your legs contract. We don't hear a cardiac or a heart muscle contracting either. You're hearing those valves close. And so with that lubbed up, that lub are the AV valves closing between the atriums and the ventricles. So that's that first, it's the beginning of contraction. It's that first atria are sending information to the ventricles. And and as the ventricles have a little bit of pressure, they close those doors, they close those AV valves behind them. The second, the DUP, are the next set of valves. They're the semilunar valves, your aortic semilunar valve, your pulmonary semilunar valve. And so, Mike, we're just hearing those valves close. The little bit of pause, and Mike, is your heart relaxing? It's filling with blood before it has to contract, and and close valves again. Now, if you hear a heart murmur, there's generally means, and you're hearing an incompetent valve. Again, when those valves close behind it, just like you're closing the door, it should have a quick, crisp door closing sound. A quick, crisp lub. It's just closed. However, if it's not closing all the way, you have a little bit of blood squeezing backwards, and it almost sounds like a gurgling type of sound as you have some blood flowing backwards. This is your heart murmurs, and you can hear blood flowing in a direction it shouldn't be anymore. Now, when you go to the doctor and they take their stethoscope and they put it on different parts of your chest, and they're telling you to breathe deep, and one of the things they are looking for as you are sitting there and they're putting their stethoscope all over your chest is they're listening for the different valves. And you can hear your valves opening and closing at different parts a little bit better on your chest. And so if they're doing upper right of your chest, they're listening for the aortic valve. Lower right, they're looking for the tricuspid. And when they go to the left side, they're looking for the pulmonary valve. And or below that, your lower left are listening for that mitral valve or that bicuspid valve. So there is a reason why they're putting their stethoscope in all different places. They're listening to those valves to see if they close nice and crisp or if there's any murmuring happening. Now, as we have all of this electricity traveling around the heart, and we know our heart is beating and it's sending blood throughout the body out to the lungs. And this flow of blood through the heart, it all follows a cardiac cycle. We have to have part of our heart relaxing and filling with blood, and then it undergoes the contraction to push that blood out. Now, anytime we talk about the contraction part of the heart, we have systole. That's your heart contraction. Relaxation is your diastole. This is when your heart is relaxing and filling with blood. Now, my way to remember the difference, maybe it's a little morbid, but you are never more relaxed than when you die. You're not. And so that's just my way of remembering it, because they're two very different words and they mean completely different they have two completely different meanings. And so the relaxation, the diastole, is when your atria, your ventricles are filling with blood. And when they have atrial or ventricular systole, that's when they're contracting and pushing that blood out of those chambers. Now, so part of this, we've got filling and we've got contracting. And so just our different phases of the cardiac cycle. Number one is we have ventricular filling. This takes place in mid to late diastole. Again, relaxing. Those atrioventricular valves are open. The pressure's low. The ventricles are just filling with blood. Blood is coming for the atrium and going into the ventricles. Now, about 80% of the blood that goes into the ventricles goes there passively. They go from a higher pressure in the atria to a lower pressure in the ventricles. Then the atrials undergo atrial systole, atrial contraction, and then they push that last little 20% of blood into the ventricles. So we try to get all the blood from the atrium into the ventricles. Now, the volume of blood that is in a ventricle at the end of ventricular diastole, so it's how much blood can that ventricle hold, it's called end diastolic volume. Now, we're going to do a little simple math, and so if you've got a piece of paper handy, write down the number 100. Approximately 100 milliliters of blood are in one ventricle after it's completely filled from the atrium. So end diastolic volume is approximately 100 milliliters. Now, ventricular systole. Now we have to contract because we've got 100 milliliters of blood in that ventricle and we want to push it out, whether it's to the lungs, whether it's to the body. The atrias are done doing their job. They're going to relax. They push their blood into the ventricles. They're good for now. The ventricles are going to start to contract. Now, as the ventricles are starting to contract, just even the slightest bit of contraction will generate enough pressure to close the atrioventricular valves. Again, now we have blood in the ventricles, we're going to close the door behind it. And we're going to close that door behind us. So that little bit of pressure closes the AV valves. We don't have blood flowing backwards because valves try to prevent backwards way of flow of blood. And we have, right at that time, when your AV valves are closed, because you have just a little bit of pressure to close that door, but we haven't moved any blood out of the ventricles yet, we have what's known as isovolumetric contraction phase. And I'm like, you haven't generated enough pressure to open the semilunar valves, but you've generated just enough pressure to close those AV valves behind you. So, we've generated just enough pressure where all the valves are closed. And I'm like, nothing's actually moving yet. But as the ventricles generate more and more pressure, their pressure gets large enough that it will force those semilunar valves open and blood will leave those ventricles. It will leave the heart. Now, there is still a volume of blood that will remain in the ventricle after contraction. And I'm like, not all 100 milliliters is going to get pushed out. That would be great if it does, but it doesn't. Now, on average, here's the math part, write this down. On average, your end systolic volume is approximately 25 milliliters. And so we had 100 milliliters in there at the end of relaxing, and then at the end of contracting and trying to push all that blood out, you still have about 25 milliliters left. Now, then we have again isovolumetric relaxation. This is early diastole. This is the ventricles have pushed their blood out, and so the ventricles are done, they want to start relaxing. And then the atria are relaxed and they're filling. So the ventricles are done doing their job. The atria haven't started doing their job yet. They're just relaxing and filling with blood that's coming from the lungs or is coming from the body. Now, when the ventricles push the blood out into the aorta, into the pulmonary trunk, that blood doesn't like to be in those smaller blood vessels. Compared to the size of the ventricles, those blood vessels are small. Even though the aorta and the pulmonary trunk are large, they are still smaller versus the ventricles themselves. And they don't like to be in that confined, smaller area. And so it generates some extra pressure, which, because of that blood wanting to go back to the heart, if it can, because it's like, we don't like it, let's go backwards. That backflow of blood is what closes those semilunar valves. It closes the door behind it. It's like they escaped through it because they were shoved through with pressure. And then when they tried to go back, they all slammed against the door and closed it behind them. Now, when they all kind of, when that blood kind of slams against the door behind it, it causes what's known as a dicrotic notch. It just means all of a sudden you get a little bit of extra pressure in the aortic blood vessel. We can actually see that. I'm just going to jump ahead to this. And when we're looking at the pressure, and I'm like, as we pump that pressure into the aorta, as it wants to come back, and I'm like, it wants to come backwards. All that blood in the aorta doesn't like it. It wants to go back into the left ventricle. And I'm like, when it does that, and I'm like, the pressure starts to go down because the blood is starting, some of it's flowing away from the heart. But as some of it slams against those semilunar valves, it all of a sudden has this quick little increase in pressure. So you get that little dicrotic notch. Now, when the atrial pressure exceeds that of the ventricles, we start all over again. Your atrioventricular valves open, the blood from the atrium are going to go into the ventricle, and we start all over again with blood pumping and moving throughout the heart. So it's this constant, blood going in, blood going out, ventricles filling, and I'm like, atrials contract and push whatever blood they can. You have about 100 milliliters in here. And I'm like, at some point when they're starting to generate pressure, they close the valves behind them. They close the door behind them. But they haven't had enough pressure to open the semilunar valves yet. But when they generate enough pressure, they do push those semilunar valves out or open. All the blood escapes. There's still a little bit of volume left in here. But after they pushed it out, it's, as the blood wants to go back downward, it closes the semilunar, and nothing's really moving yet. Then again, the atria are going to start to fill with blood, and then they'll start to fill the ventricles, and we start all over again. Now, when we're talking about cardiac output, we want to know if someone's heart is doing the job it is. A lot of times they start talking, well, what's the cardiac output? How much blood is your heart pumping? So cardiac output is looking at, how much blood is pumped by your ventricles in 1 minute. So not just with every beat, but how much blood is actually getting pumped out of your ventricle in 1 minute. So cardiac output, since we're doing it on a time, 1 minute, we have to know the heart rate. How many times does the heart beat per minute? And then we have to look at stroke volume. And you're like, what's stroke volume? Stroke volume is the volume of blood that is pumped out by each ventricle for every beat. Now, and I'm like, if you remember, the ventricle fills with about 100 milliliters of blood. After ventricular contraction, you have about 25 milliliters left. Here's where we get to some math. 100 minus 25 is 75. That means every time our heart beats, it pushes out about 75 milliliters. Now, on average, if we do a heartbeat, and I'm like, our heart rate, which again can vary, and I'm like, it can also be 75 beats per minute. And if we do 75 times 75, and I'm like, I'm even getting my calculator because I'm like, I can't remember if it's my exact number or not. And I'm like, but if we have 75 beats per minute times 75 milliliters, it pumps just over 5,000 milliliters of blood per minute. A little over 5,000 milliliters is the same thing as 5 liters. You just divide by 1,000. And so on average, you are pumping out a little over 5 liters of blood out of your ventricles every single minute. That's cardiac output. Now, some things that can change with stroke volume. Again, this is how much blood is pumped out by your ventricles. That's just the stroke volume. And I'm like, how much gets pumped out? 75 on average. And again is end diastolic volume minus end stroke volume. 100 milliliters minus 25 milliliters equals 75. Now, your end diastolic volume is affected by the length of your ventricular diastole. How long is your ventricle filling? If it fills for longer, you may have more than 100 milliliters in there. Same thing with your venous pressure. If there's more pressure pushing blood in there, you're going to have more. And systolic volume is affected by your arterial blood pressure and the force of your ventricular contraction. And I'm like, is how hard can your ventricles contract? If they can contract really hard, you're not going to have as much volume left in there. Same thing if your arteries have a really high blood pressure, your ventricles have to pump really hard to get blood into a high pressure. You may have extra blood left in your ventricles. If you have a low blood pressure, blood doesn't mind going there because it likes to go from higher pressure to lower pressure, and you might be able to send more blood out. I was going to say, and there's 3 main things that can affect stroke volume. Again, they're all going to have something to do with affecting your systolic, your end diastolic, or your end systolic. Now, the 3 main factors, preload, contractility, and overload. Preload, and you're like, these sound horrible. They're not so bad. Preload just means how stretchy those cardiac muscle cells are before they contract. It's the Frank Starling law of the heart. Now, it just means at rest, your cardiac muscles are shorter than their optimal length. Our heart wants to be nice and stretchy. So the most important factor that's stretching cardiac is our venous return, how much blood returns to the heart. If you have a lot of blood returning to the heart, your heartbeat is slower, and I'm like, it stretches more, it's easier to pump out. Kind of the same thing, I'm like, they always tell you to stretch before you go do exercise. As your muscles are stretchy, they can contract easier. And so we want to be able to stretch those cells out. And so if you have a lot of blood going into the heart, that stretches those muscles out before they contract, which means now you can contract harder to pump more blood out if you need to. Now, and I'm like, exercise improves how much blood returns to your heart via veins. And so this is why I'm like, people that are exercise, and I'm like, they have more blood getting in there. It stretches more. They have a larger volume. They can generate a stronger contraction, and their heart doesn't have to beat as often. So they have a slower heartbeat. The other part is the contractility, is what is the actual contractile strength at your given muscle length. This is independent of your actual muscle strength itself and your end diastolic volume. So this is just the strength of the contraction. Now, a lot of this is, I'm like, the strength of your contraction, contracting really hard versus contracting really soft. Doesn't matter, how stretchy your muscles are. However, there are various drugs and there are various ions that can change the strength of your contraction. One is extra calcium. Extra calcium can have an increase in your depolarization, and you can have more cross-bridges attaching, and you can have a bigger muscle contraction. There's also a whole slew of drugs, that also can increase your muscle contraction, which is why some of these are given if they know your heart is having problems. It will help your heart contract. There are some things that can then decrease. They're called negative inotropic agents. They just decrease the strength of your muscle contraction. If there's too much acid in your blood, too much potassium, or anything that's going to block calcium channels, so calcium can't get where it needs to go, your muscle contractions are going to be weaker. Now, because of this potassium, this is why after people have heart surgery, they really want to limit how much potassium they have in their diet, because too much of it can actually cause weaker muscle contractions, which isn't great if you're trying to recover from some type of heart surgery. And the last thing that can affect stroke volume is afterload. This is the pressures the ventricles have to overcome to eject blood. Your heart is sending blood into the aorta, and it is sending blood into the pulmonary artery, the pulmonary trunk. Because it's a smaller volume, blood doesn't want to be there. And it takes that heart has to pump against the pressure that's already there. So if you have hypertension, if you have a blood pressure, it means the blood that's already in the aorta, right outside the heart, is going to be really high, which means your heart has to pump really hard to send blood somewhere where there's already a lot of, a high pressure of blood. And so hypertension increases afterload. It's just the pressure that the ventricles have to generate has to be even higher to be able to send that blood out. Now, if you have to pump really hard, you're going to have extra blood that's still going to be left in there. So you're going to have a reduced stroke volume because you're going to have extra blood. You have an increased end systolic volume. You have extra blood sitting in your ventricles. Instead of having 25 milliliters left, maybe now you have 40. Because your ventricles pumped really hard, but your blood pressure was so high, it was just too hard to pump all of that out. Now, some things that can affect your heart contracting. One is your heart's all controlled by the autonomic nervous system. Again, we can't physically control our heart. However, things that can happen though is your sympathetic nervous system, when you're under stress, it can be activated by some type of emotional or physical stress. When that happens, our body submits or releases a hormone called norepinephrine, and it causes your pacemaker, your sinoatrial node, to fire more rapidly, which is going to increase how many contractions happen. So you have an increase in your heart rate, and you have an increase in contractility, and it's going to relax faster so that we can pump blood as fast as we can throughout the body. Now, the opposite, if you're at rest, your parasympathetic nervous system kicks in, and we want a slower heart rate. The chemical acetylcholine will hyperpolarize your pacemaker cells. It's going to open excessive potassium channels. It's going to take longer to reset everything. And so, we're going to have a slower heart rate. And now, that doesn't always have an effect on contractility, like strength of contractility, but your heart rate won't contract as often because it takes longer to reset everything. This in your book, it's page 682. It's kind of going back and forth, and it's a nice diagram just looking to see what can affect cardiac output. And these are different things that can affect heart rate, that increase heart rate. These are all things that can increase stroke volume. So how much volume are we sending throughout our body? And our stroke volume, that end diastolic minus end systolic. Now, I said before, yes, there are some chemical regulators of your heart rate. Epinephrine, the hormone, it increases your heart rate and contractility. This is why for a while there was a lot of diet drugs that had epinephrine, and people were having severe heart problems. There were heart palpitations, they were having heart attacks, and yes, there was lots of lawsuits involved, and but you never want to take extra epinephrine because it's going to have, wreak havoc on your heart rate. Thyroxine is another hormone that increases heart rate, it just enhances the norepinephrine, and I'm like, and the epinephrine. So norepinephrine, again, same basic idea, it's just a slightly different hormone. And I'm like, but it increases your heart rate. It enhances the effects of these two hormones. The other chemicals are ions. Intracellular and extracellular ion concentrations need to be maintained for normal heart function. As I said with your potassium, people that are having any type of heart surgery, their diet is monitored closely, because if you have any type of calcium or potassium imbalance, your heart is affected. Example, hypocalcemia is a decrease in calcium that depresses your heart rate. And I'm like, hypercalcemia, too much calcium in your blood, around your cells, is going to increase your heart rate and contractility, the strength of your contraction. Hyperkalemia with K, and I'm like, this is potassium, and I'm like, it can cause heart block and cardiac arrest. Again, heart block, because it's going to alter electrical activity. It might not be able to reset itself, and it's going to cause that heart block, where electricity can't go from atrium to ventricle through that AV node, and it can go into cardiac arrest. You're not going to pump blood to various parts of the body, including the heart. And then hypokalemia is not enough potassium, which means you may have, if there's not enough, you have a feeble heartbeat. It's not going to be able to pump enough. It may develop into arrhythmias, where your heart just isn't beating in any particular type of rhythm. Some other factors that can influence heart rate, your age. Fetuses have a really fast heart rate. And I'm like, if you've ever known anyone that's, like they put the little fetal heart rate monitor on it, and they're beating, instead of 75 beats per minute, it's like double that. And I'm like, it sounds crazy. Females usually have a faster heart rate than males. Any type of exercise increases your heart rate. Body temperature, the warmer you are, you have an increased temperature. Or increased, anytime you have an increased body temperature, that increases your heart rate. If your heart rate beats fast enough, if it's over 100 beats per minute, we call it tachycardia. If it beats fast enough, it may lead to fibrillation, where there's no downtime of relaxation, resetting, and it starts to beat abnormally. Bradycardia is the opposite. Brady means slow, and I'm like, it just means the heart rate is slower than 60 beats per minute. And if it's too slow, you might not be getting enough oxygen to various parts of your body. However, and I'm like, people that do endurance training, that are running marathons, the ultra marathons, their heart, they have worked their hearts and their cardiovascular system so well that their heart doesn't have to beat as often. And so it's very common that they have heart rates of lower of like 45 beats per minute. And like that, they always have to tell the doctor, like, I'm just in really good shape. I'm not dying. And so I'm like, it's great. You've got a nice, strong, thick heart. And I'm like, it doesn't have to pump as often because it's so efficient. Congestive heart failure. This is, your cardiac output is eventually so low. It's a progressive. It just isn't something that happens one day. Your cardiac output, your heart is not beating enough times per minute, and like you're not sending enough blood out of your heart per minute, that eventually your tissues are just not getting the oxygen they need. Now, there are several things that can affect that or cause that. Occasionally, you can have clogged arteries or coronary atherosclerosis. And I'm like, your arteries are getting clogged. And I'm like, so you're not getting blood flow where it needs to. Persistent high blood pressure, where your heart can't pump that blood out of the heart because the pressure in those blood vessels are so high. Or if you've had multiple myocardial infarctions or infarcts, I'm like, that's multiple heart attacks that you have, permanent damage to that heart muscle every single time. Some other imbalances you can get if your left side of the heart is failing, that pumps blood to the lungs. If your left side fails, you can get what's known as pulmonary congestion. If you can't pump blood out to the body, it backs up backwards and goes to the lungs, because that's where it just came from. If you're on the left side, it came from the lungs, and if you can't pump it out, it backs up in the lungs. The opposite, if your right side fails and we can't pump the blood out to the lungs, it's going to go backwards, and you start to have blood pooling in your body organs, leading to this edema, and I'm like, which is your tissue starting to fill with fluid. Failure of either side weakens the other. So if your right side fails, eventually it will affect your left side, and vice versa. Treatment, they can try to remove fluid. They can try to reduce the blood pressure. They can try to reduce afterload, again, trying to reduce your blood pressure. And they can try to give you some type of either chemicals or ions to try to increase contractility. few more sides. Some developmental aspects of the heart. Some of these we talked about in lab. But a fetus, yes, that's beating a good 150 beats per minute. But because, again, the fetus isn't sending any blood to the lungs to get oxygen because they're not breathing, they're going to bypass that pulmonary circulation. So the one thing they have that can bypass that pulmonary circulation is they have their foramen ovale. And I'm like, it connects the two atria. So it's right inside that interatrial septum. And I'm like, instead of sending all that blood to the lungs, well, let's just loop it back and send it out to the aorta. Start, just keep it going. It's pointless to send all of that blood out to the lungs. Now, and I'm like, as an adult, that hole goes away, and the remnant, we call it as the fossa ovalis. Sounds like a fossil. Your ductus arteriosus, again, we have this extra chamber. Instead of sending all this blood out to the lungs through your pulmonary trunk, we have this extra duct. Well, let's send this blood right to the aorta. So it connects the pulmonary trunk to the aorta. That again goes away after birth because now we want to send all that blood to the lungs to get oxygen. And there's this little tiny remnant. It's a little tiny ligament, and they call it the ligamentum arteriosus or arteriosum. Now, both of those close at or shortly after birth. Always crazy, all these things that have to happen right after that poor baby is just born. Lots of things. Now, as we get older, some age-related changing, because, aging sucks, and this is why. Now, and I'm like, as you get older, your valves, your bicuspids, semilunars, tricuspids, they start to get harder. And so you start to get hardening and thickening of your valve flaps. Now, anything arteriosus, and I'm like, it's making them less elastic, so they're not as stretchy anymore, and they start to get thicker, which means they might not, it's just like a door. If it started to get thicker and not stretchy, that's not a good word, doors aren't stretchy, but I'm like, if your door is not as easy to open and close, it takes more to open it, takes more to close it. You're going to have a declining cardiac reserve. How much blood, is going to be filling. You can have fibrosis of cardiac muscle. As some muscle eventually tissue dies, and it's going to get replaced with a fibrous connective tissue. We can also have atherosclerosis. Now, and there is a difference between atherosclerosis and arteriosclerosis. They sound almost the same. They look almost the same. Both have the prefix scler in it, which means hardening, but there's two different reasons they can harden. Arteriosclerosis means they're hardening. It just means they're not as elastic. They're not as stretchy. Now, if an artery is not as stretchy, it's a better chance of it bursting. Like a rubber band, if it's nice and stretchy, it shouldn't break. If you have an old rubber band that's not as stretchy anymore and you try pulling on it, it will break. Same thing with blood vessels. However, the atherosclerosis is the blood vessels harden, that's the scler part, but it's not hardening because they're not elastic. It's hardening because now they have plaque. They have this buildup inside the arteries that's decreasing blood flow. Now, to get around that, because we've got some very important blood vessels, especially your coronary arteries around the heart, that this likes to happen in, and there's a couple things they can do. One, if you've ever known anyone that's had balloon angioplasty, they usually go in through the femoral artery, and they're going to send this big long tube, and this balloon isn't blown up right away, but there's your blockage, and they're going to put this big long tube, snake it through your arteries, eventually get all the way even to the coronary arteries in the heart, all from the femoral. They're going to find where that blockage is, and then they're going to blow up the balloon while it's in there. The goal, or the hope, is that when they blow up the balloon, it will kind of pack that plaque down. And now you have a bigger opening. So there's your balloon angioplasty, if you ever knew anyone that had it. They literally took a balloon. It's not filled up as they're trying to send it through everywhere. But they blow it up, and they are manipulating that balloon all the way from your femoral artery all the way up into your heart. If you've ever known that's had a stent put in, this is more of a permanent opening. And so if this works, great. If they don't think this is going to work, or it might start all over again, here's that plaque. Again, they're going to go in usually from the femoral artery, work their way up. They're going to send this tiny little tube that has this wire, it looks like chicken wire, thing that's all scrunched down chicken wire with a deflated balloon in it. And they're going to manipulate that all the way into that blocked artery, They're going to blow up the balloon. They're going to stretch out that chicken wire stent. Then they're going to remove the balloon, and now you have this chicken wire stent. No, it's not actually chicken wire. This chicken wire looking stent that is holding that blood vessel open. And so it's compressed the plaque down, but the stent stays in to keep it so that plaque doesn't build back up. It's not going to compress and stick back to each other. Now, if you've ever known anyone that's had bypass surgery, what actually is happening? Right here on the heart, there's a big coronary artery, and here's the blockage, which means all the tissue down here is not getting oxygen. And if your left ventricle is not getting oxygen, severe heart attack, can likely cause death. And so we're going to bypass it. We still need to get oxygenated blood down here, but it's not going to flow past this. So what they'll do is they'll take some of a vein, and I'm like from your lower leg, they'll go in, do surgery, remove a section of a vein. They can piece the other two pieces back together, and I'm like, but they remove a small piece of vein, they go up to your heart, they stitch one part of the vein to your aorta, and they stitch the other part of the vein to that coronary artery, but down from that blockage. And so now anytime your heart beats and you have oxygenated blood in your aorta, some of it is going to travel through that vein that was put in and is still going to provide the rest of that left ventricle with oxygenated blood. Crazy things that they think of, but if you ever known that someone who had bypass surgery, it's literally what they're doing is they are bypassing the blockage by putting in this extra vein going somewhere. All right, on to some review questions. The plateau portion of the action potential in your contracting cardiac muscle is due to, let's get through these. It's those calcium ions, the fact that you have calcium ions going in, and I'm like, in this large influx of all of them going in, it stays at that high plateau of the action potential. The stimulus for the heart's rhythmic contraction comes from the pacemaker potential. The fact that you have those open sodium windows, that you always have sodium going in, it makes it kind of unstable, and it always wants to contract. In a normal heart, which of the following structures is responsible for setting the heart's pace? So, which was the pacemaker? It's the sinoatrial node is the pacemaker. Cardiac output is determined by what? Cardiac output, and it is a multiplication. Cardiac output is it should be pink and orange, or P and O. It should be your heart rate, how many beats per minute, times your stroke volume, how much volume is actually leaving your ventricles. And then the lubbed up heart sounds. If you're listening to someone's heartbeat, and I'm like, there's the two sounds, those are produced by the closing of the atrioventricular valves, the first, and I'm like, and then the closing of the semilunar valves, the second, the lub and the dup. And the last question, in terms of blood flow, why is it important that atrial diastole occurs just as ventricular systole begins? So atria relaxing just as ventricles are contracting, and it's because the atrial need time to fill with blood in preparation for ventricles to fill with blood. So the atria need to relax and fill with blood before the ventricles will eventually fill. So there's the end of that PowerPoint. Make sure you read through it, look it over, make sure you do the review sheet for the test.